Question 25, which of the following is the most likely diagnosis? And it's all respiratory. A 61-year-old man presents to the clinic with complaints of persistent cough and worsening shortness of breath over the past couple of years. So again, acuity is always really important. Past couple of years, that's a long time. Cough is productive, especially in the mornings, yellow sputum, blah, blah, blah. Okay, he has wheezing, no fever, chest pain, hemoptysis, or weight loss. He has a 40-pack year smoking history. Kind of unsurprising, but he also works in a shipping warehouse. So maybe it's one of those weird pneumoconioses or hypersensitivity, pneumonidities. Let's just keep going for now. Physical exam, sounds are coarse bilaterally with scattered wheezes. Again, prolonged expiration. So that's really it. What's the diagnosis? So we've got a few things here. Let's just start with probably the elephant in the room, the 40-pack year smoking history. Right away, when you see a large smoking history, two things should come to mind: COPD and lung cancer. So let's go through here. We've got emphysema. That's one of our types. And then we've got our chronic bronchitis, another type of COPD. Is there anything else? Idiopathic pulmonary fibrosis? No, probably not. Let's talk about some of the other answer choices here. C, idiopathic pulmonary fibrosis is a restrictive lung disease, not obstructive. And we have wheezes. As we talked about in the previous video, wheezing is indicative of obstructive lung disease. You can imagine an obstructive lung disease might look something like this. This could be asthma during an asthma attack or chronic bronchitis, just from inflammation over time. You get these thickened walls that let less airflow through. So less is going to be able to make it through, and whatever does make it through is going to vibrate around in the pipes and make noise, and that's what we hear as wheezing. So think obstructive lung disease if you hear wheezing, asthma, chronic bronchitis, or the like. So I'm going to cross off our fibrosis because that wouldn't be wheezing. That would be more like crackles. Again, as we talked about earlier, crackles tend to be fluid in the lungs, like a pneumonia, congestive heart failure, or can be alveoli or even bronchi just popping open as we inspire. So asthma is another form of obstructive lung disease. Asthma for a couple of years, I think it's getting worse for a couple of years with productive cough, 40-year smoking history. It just makes more sense to be something else than asthma, so I'm going to get rid of that one. Bronchiectasis, I think, is a commonly misunderstood pathology. Bronchiectasis, if we were to transect a bronchi, right, so we're looking at a cross-section of it here. Bronchiectasis is eventually dilation of the airways, which sounds like a good thing, but it's actually not. And dilation is not the problem either. It's just more like a consequence. The problem with bronchiectasis is from infections, tumors, obstructions, something that damages the bronchi. So over time, they get scarred, they get damaged, and damage means less ciliary function. So you tend to get gunk accumulating on the inside. It's a mucus trapping. And over time, this mucus that accumulates is actually a nidus for infection. So as little microbes tend to seed this mucus here, maybe you got some Pseudomonas or some anaerobes coming in and invading, that's going to cause inflammation and more damage. More damage means more bronchiectasis, more dilation. And then over time, you've still got a bunch of mucus and a bunch of scarring, and it's just a vicious cycle that keeps going. So how do you tell the two apart, bronchiectasis from chronic bronchitis? They both can present with cough and sputum, productive coughs. Bronchiectasis tends to present with more sputum. If you've ever seen a question that says somebody's producing seemingly cups of sputum, which is absolutely disgusting to think about, but that's real for bronchiectasis. It's because it just gets stuck and accumulates over time, and it just can't get out because the cilia are dead. And like I said, this mucus tends to get infected. That sputum tends to smell badly once it's infected. You could even see streaks of blood or even just frank hemoptysis. We don't really have that here. This was more of an insidious onset over years. No mention of excessive sputum or sputum that smells badly. So I think we're good to cross this one off. Also, there's no risk factors like no cancer, no recurrent infections. All right, so how do we choose between the two types of COPD? Well, emphysema is damage to the alveoli. So again, if we draw out our alveolar sacs here, right, over time, we get damage to the walls, right? So these walls tend to collapse and you end up with basically just one plastic bag of alveoli, as opposed to multiple sacs. You now just have one. So there's a lot less surface area. And that's the problem with emphysema. So you have less surface area to do gas exchange. However, that's not going to obstruct an airway like chronic bronchitis would. So emphysema may not on its own present with wheezing, but chronic bronchitis could. So the correct answer here is going to be chronic bronchitis. Also, because we have productive sputum and emphysema typically doesn't present with that on its own, because again, it's affecting the walls between the alveoli, not the bronchi, where you have the cells producing mucus in the first place. The goblet cells are not in the alveoli. They're higher up in the bronchial tree. In real life, patients tend to have a combination of both chronic bronchitis and emphysema, but on tests, they tend to ask you to pick just one.